Okay, so welcome everyone. Let's pull up the slides first, and then I'm going to give a brief introduction of the presenters. Okay, so welcome everyone to the CIPC pilot presentations, and I'm Jiyoun Song. I'm the co-PI of this project, and today I'm very happy to have 3 of our pilot PIs to present their projects. So we have Dr. Maureen George, Dr. Bevin Cohen, and Dr. Jiyoun Song. So Dr. George is the professor of nursing and the director of the PhD program at Columbia School of Nursing. And Dr. George's program research focuses on reducing health inequity in the vulnerable populations with chronic respiratory disease. And her primary research interests include community-based participatory research with poor and minority patients and their healthcare providers to understand how self-management preferences and patient-provider communication can influence treatment choices. Okay, so she has extensive experience as nurse scientist and behavioral scientist designing, testing, and dissemination intervention informed by innovative, qualitative, and mixed methods. So Dr. Bevin Cohen is the director of the Center for Nursing Research and Innovation for the Mount Sinai Health System and associate professor in the Brookdale Department of Geriatric and Palliative Care Medicine at the Icahn School of Medicine at Mount Sinai. She's an epidemiologist and she also has an RN license. Dr. Cohen's major focus of her study is supporting nurse-led research in the clinical setting to improve patient care process and outcome. Her current program research focuses on improving systems and processes for providing actionable education to patient and caregiver to improve the advanced care planning. Dr. Jiyoun Song is a postdoctoral research fellow at School of Nursing at Columbia, and her research focuses on developing clinical decision supporting system tailored to the individual characteristics of patient in order to improve the patient outcome and reduce negative improve the patient outcomes. To achieve this goal, Dr. Song builds predictive models through multi-dimensional methodological approaches, including quantitative statistics and machine learning. Her most recent research focuses on utilizing untapped data streams such as clinical notes and verbal communication, and to extend the possibility of data science as a decision-making decision support tool. So I'm going to hand it over to Dr. Maureen George. So we are going to, each presenter will have 15 minutes for their presentation. We'll like the audience to send your questions through the chat. We are going to have about 10 to 15 minutes Q&A in the end. So I'm going to hand over to Dr. George.
Thank you, Dr. Shang. I'm pleased to present the first aim of our pilot project and thank the P20 pilot funding stream to allow us to examine patient and caregiver decision-making in advanced lung disease. I'd also like to recognize that this was a collaborative effort from Columbia University School of Nursing faculty and students, as well as those from Teachers College, Mailman School of Public Health, and those at Pulmonary and Critical Care Division in Weill Cornell, which includes one of the research assistant who's now at SUNY Upstate. So the majority of the individuals that I enrolled into AIM-1 were suffering from an interstitial lung disease. And interstitial lung diseases, or ILDs, are a group of over 200 heterogeneous restrictive diseases that cause a chronic and progressive condition due to underlying fibrosis or scarring of the lung tissue in the space around the air sacs or alveoli. They occur mostly in the 6th decade of life or later in the setting of often multiple chronic conditions. And the life expectancy can vary widely. If you have mild sarcoidosis, you could have a normal life expectancy, to some of the pulmonary fibrosis, which may have a life expectancy of just a year or 2 from diagnosis. We don't really know the prevalence of ILDs because they are insidious in their development, often presenting very late in the stage when they become quite symptomatic. But based on the most current information that we have, you can see that the United States is represented here in yellow, is indicating that about 10 out of 100,000 individuals will be diagnosed with an ILD, which is a relatively small number of individuals. These ILD patients suffer a common symptom cluster, which is characterized by progressive breathlessness, fatigue, much reduced functional ability in their day-to-day activities of daily living, as well as pulmonary disturbances that impact their sleep. Their outcomes, whether that's symptoms or just prevention of disease progression, can be improved if they adhere to a complex regimen of different self-management strategies that require a combination of medications and delivery methods, as well as physical therapy and pulmonary conditioning. Some individuals will require oxygen, all need to stop smoking, and all need to follow a healthy diet. Now, in comparison to COPD, which is a much more common condition, which is indicated here in the darker blue, the ILDs represent a smaller cost in terms of US dollars, costing about $1.8 billion. And most of that is associated with costs related to non-adherence because of poor symptom management requiring hospitalizations. So if these symptomatic patients with advanced lung disease were to be referred to palliative care, we think that their outcomes could be improved, but several studies have shown that they're rarely referred to palliative care, instead staying in specialty pulmonary care because pulmonologists say that they lack the time to discuss palliative care during office visits, that they lack confidence in the ability of palliative care providers to provide the specialized care that these patients with advanced lung disease need. And they believe that the palliative care referral might threaten the relationship they've already developed with the patient and their family. When we talk about one specific group of patients with advanced lung disease, those with end-stage COPD, which are not ILD patients, but if we can extrapolate from those experiences that we know that 65% of them have never spoken with their healthcare provider about the types of treatments they would want if they get too sick to speak for themselves. And that 3/4 would rather concentrate on just staying alive than talking about plans for end of life. But these kind of decisions are really important when you have a chronic progressive disease with a high symptom burden. And so we really need to revisit the idea of who's making decisions around symptom management and end-of-life planning. And we've had a progressive evolution of models of patient-provider partnerships where we started with a paternalistic model where I, as the provider, decide what's best for you based, hopefully, on my clinical experience and clinical practice guidelines. And then I give you that fact, informing you using patient education and transactional knowledge. And I then try to move to an interpretive model where I give you the facts based on evidence and based on my clinical practice to help you find your preferences. And then hopefully arriving at the point where we deliberate together, where in addition to me giving you the facts and helping you find your preferences, I tell you what I would prefer in terms of your management. And so we're really moving then from a comprehensive model in which we use evidence-based guidelines, patient education, to arrive at a intervention that helps patients identify their preferences and that we enter into shared decision-making together. If we had that kind of patient-centered biopsychosocial approach, we think that communication would be better and outcomes would be better. But data even from as recent as 2013 have shown that 3/4 of all physicians continue to employ a physician-directed biomedical approach to decision-making. And so we really think that there is an opportunity to combine our clinical expertise with the best research evidence, with understanding the needs and preferences of patients to arrive at shared decision-making in advanced lung disease. And so our rationale for writing this pilot was that we believe that patient, caregiver, clinician communication around self-management decision may be suboptimal, but is critically important if we want to support the initiation, implementation, and persistence of complex self-management. And that shared decision-making in the context of that, those decisions would actually improve outcomes. So today I'm going to report just on the first aim of our pilot, which was to develop a communication strategy training for clinicians who are working with these patients, which we call Breathe ALD, which stands for Brief Intervention to Enhance Adherence to Treatment and Health Advice in Advanced Lung Disease. So in order to develop this communication strategy training, we needed to talk to patients and caregivers. So we used semi-structured interviews to explore symptom burden, self-management, health beliefs, and preference among 10 patients and 10 caregivers, 9 with interstitial lung disease and 1 with end-stage COPD. I was the single interviewer who interviewed them following an interview guide that was developed in an iterative fashion. We conducted our interviews over Zoom, which was HIPAA compliant. And then an interdisciplinary coding team helped us to code those transcripts. We used a code book to make certain that we had agreement and consensus building on what those codes were. And we actually performed 2 different types of analysis. The first was a conventional content analysis of the individual interviews. And the second was a dyadic interview analysis where we took 6 matched patient caregiver dyads to identify their stories about their disease and disease progression, looking to identify stories that were concordant, discordant, or complementary. And I'll talk a little bit more about that in just a minute. So the patients participated in this 45-minute semi-structured interview and completed a battery of different surveys using a link where they entered their data directly into REDCap. And likewise, the caregivers did similar data collection, just with fewer surveys. So let me go through some of the results first to describe the sample in more detail. We had 10 patients and 10 caregivers. Most of the patients were male, most of the caregivers were female. Most were white and college educated or had a graduate degree. The majority of both patients and caregivers were retired. And while patients described themselves as most often living with a spouse or partner, caregivers reported that they lived mostly alone. Those caregivers were predominantly spouses or partners, although several of them were children. And I don't think it's surprising to see, as I said before, that this is a disease that occurs later in life, that the patients had a mean age of about 76. And again, maybe not surprising is that the caregivers, because most of them were partners or spouses, had a mean age that was relatively close to that, just around 70 years of age. And also to kind of contextualize everything, we administered 2 measures of health literacy. The first one, the NVS, is the newest vital sign. Scores of 4 or higher indicate that there is low likelihood for health literacy problems. So you see some of one patient and two caregivers scored below that. But we also administered another short assessment of health literacy in English, where a score of greater than 15 is a measure of adequate health literacy, and every individual scored higher than that. So another reason why administering more than one health literacy measure is the standard now to understand a pretty complicated characteristic to measure. Now let's talk a little bit about patient symptom burden to contextualize the qualitative data that I'm going to be showing you. The first measure is the MMRC, which is a dyspnea measure or a measure of breathlessness. It has a range of scores from 0, meaning breathless only with strenuous exercise, up to a score of 4, which means easily breathless with minimal exertion. Our patients reported scores between 1 and 4, so they were all symptomatic, and the mean suggested that they had a fair amount of symptoms. We also measured PROMIS scores using both the fatigue and pain short form scores, and the cut point for having symptoms is a score greater than 55, so our individuals did not score as having more than the population standard complaints of pain or fatigue. And then we gave 2 measures of quality of life. One was a generic quality of life measure, which is the SF-36, and we followed that with another measure of quality of life that was pulmonary specific. First, looking at the generic quality of life, or SF-36, in this SF-36, the cut point for there being an individual who has worse quality of life is anything less than 50. So you can see that these individuals had both in physical functioning and role limitation scores less than the mean of 50. And likewise, they reported lower quality of life in terms of general health and changes in health. When we look specifically at the St. George's Respiratory Questionnaire, which is a pulmonary specific quality of life measure, here we're looking at a different scale. It's scored from 0 to 100, and the higher the score, the worse your quality of life. And so you can say that individuals here had excessive impairment in their activity, which is what we would expect with advanced lung disease and a high symptom burden. And in fact, it was really interesting to see that one individual scored almost all the way out to the highest level, meaning unable to be physically active at all due to their lung disease. So the results of first the individual interview content analysis, we identified through this inductive process 5 categories that were the findings across both patient and caregiver code books. And so the first category is managing, which had to do with the medical and non-medical management strategies that patients and caregivers were using. We also included this to code around how their symptom disease or their need for oxygen or their physical limitations required a lot of pre-planning anytime they needed to leave the house. And the other thing that we thought was interesting is that both caregivers and patients managed the information that they were sharing with their other person in order to protect or assist them. So either preventing them from knowing the degree of severity of their disease or the progression of their disease. One of the things that really sticks with me is that one of the individuals said, I give it to them lighter, just as a way of describing that the news is bad. And I'm going to kind of curate that information so that I don't cause excessive worry, concern, or cause them to feel despair. Our second category was decision-making, which was pretty straightforward in terms of who and what sources of information are trustworthy for caregivers and patients to use when making decisions. And one person said, I do my own research, and that was one of the things that not only did they trust and listen to their medical team, but they also felt that it was important to talk to family and do their own research. The third category was life journey and disease trajectory, where both patients and caregivers mourn their past life because their previous health status was much healthier and they had more opportunity to travel and to do things spontaneously. And now there were a lot of physical and emotional burdens that they were experiencing in the present time, and what they expected to happen in the future. And one individual used the term to describe this: I miss the person who I used to be. The fourth category of our 5 is interpersonal relationships, where this is trust in providers and trust in caregivers. And our fifth and final category in the individual inductive analysis was quality of care, which asked the question, can providers be trained to do better at communicating around end of life and symptom burden issues? And if they can be trained, are they motivated and interested in providing better quality care and better communication? And then I'm going to wrap it up now in just a minute here. I'm talking about the results of our Dyadic interview analysis that came from 6 of our 20 participants were actual matched dyads, a caregiver and a patient. And in dyadic interview analysis, the analysis is a little bit different. You're looking for whether or not the storylines that the patient and the caregiver are given are concordant or similar, discordant or dissimilar, or complementary, meaning that maybe they have unique perspectives, or maybe they tell a similar story, but one person has a missing piece or some kind of hidden information, even a secret, has been reported sometimes in the literature. So our dyadic interview analysis found mostly concordant stories around symptom management, decision-making, and illness representation. So patients and caregivers understood their breathing problem. They understood what should be done for it, and they agreed on who should be the decision-making moving forward. But it was mostly the caregivers who provided missing elements. So there were complementary but missing elements. So these were individuals who, in the case of the caregivers, were more likely to know the name of the actual disease or its likelihood for progression or severity. And the caregivers were more likely to know that the patient was non-adherent or using non-conventional complementary alternative medicines, medical marijuana, knew that patients were refusing lung transplants, or were hiding the fact that they were exploring the possibility of putting that person into long-term care facility. So in conclusion, our interviews with caregivers and patients with advanced lung disease identified targets for future interventions that we hope to build into an intervention, a communication intervention that we trained the nurse practitioner in the pulmonary specialty program to deliver after an office visit for ILD. And this should really be focused on supporting their self-management and improving clinical outcomes. And we're going to do this pilot with 10 patients in 2023. And we just heard we got the money for that just in the last day or two. And it's really going to be focused on the data that came out of these interviews, which showed that decision-making is desired to be shared with the clinician. And that should be the goal of our training and of all office visits. So I'm pleased to tell you that this paper has been accepted for oral presentation at the International Conference on Chronic Conditions in Bangkok, where I'll be delivering this at the podium in February, and we currently have a written abstract under review for the American Thoracic Society. So a big thank you to our research team in the CIPI at Weill Cornell Pulmonary and Critical Care, and the biggest thanks to the coding team that helped me do this analysis. Thank you.
Okay, great. Thank you, Dr. George. And I just want to say it again. If you have any questions, you can send us through the chat, and we will have a Q&A in the end of the presentation. So our next presenter will be Dr. Cohen. Reminder, each presenter has 15 minutes.
Thank you, Dr. Sheng. I'm just going to go ahead and share my slides. And hopefully I've done that successfully and you all can see them. So thank you very much for the opportunity to share our progress on this ongoing pilot titled Developing a Comprehensive Program of Palliative Care for Adults with Multiple Chronic Conditions. And just by way of very brief background to set the stage regarding our goals, we know that patients who are living with multiple chronic conditions typically experience fragmented care management, and this can result in poor pain management and poor symptom control. It can also result in unplanned visits to the emergency department and admissions to acute care. And we know not only is this bad for patients and their well-being, their health, and their quality of life, it's also has a lot of negative externalities for our health system as a whole in terms of preventable healthcare costs. So with that in mind, our goal here was to develop a comprehensive palliative care program that can be adopted for use within a primary care practice to try to address some of those issues that we just talked about on the previous slide. And in order to do this, we drew upon 4 existing models of care and took pieces from each one to try to develop something that would work well in a primary care practice. So the first is existing primary palliative care models. The second are home-based primary care models. The third are home-based palliative care models. And the fourth are models of care that draw upon social determinants of health to better guide care for patients. So the setting for our project is the Columbia Doctors Nurse Practitioner Group. And for anyone who's not familiar, this is a primary care practice run by nurse practitioners affiliated with Columbia School of Nursing and in the New York Presbyterian Network, serves the greater Washington Heights community. It is a NCQA patient-centered medical home. And when we began planning this, the size of the practice was about 2,000 patients, and 15% of those were adults who are living with multiple chronic conditions. And at that time, the practice had 5 full-time primary care nurse practitioners, 2 full-time psychiatric nurse practitioners, and 1 registered nurse. Fast forward, we have gone through, the COVID-19 pandemic, come out on the other side. And with this, the size of the practice, both in terms of the number of patients seen and also in terms of the number of full-time and part-time staff has significantly contracted. So I just want to mention that, while we anticipated having a slightly larger pilot, the number of patients and practitioners that we're working with is smaller than what we anticipated due to changes from COVID-19. Pardon me, I don't want to lose my voice. So aim 1 was to explore palliative care needs of adults who are living with multiple chronic conditions in an underserved urban setting. And to do this, we first wanted to interview patients and caregivers who are receiving home care already. And we wanted to look at this group because they are receiving a high level of services. So we wanted to understand, and they are also facing, a really great symptom burden, and have many, many different providers involved in their care. So we wanted to look to this population to try to understand barriers and facilitators of their symptom and disease management, understanding, how they see discussing goals of care and advanced directives, and also, how palliative care is incorporated into the care that they receive. And with that, we also wanted to interview clinicians to explore their knowledge, attitudes, training, and experiences with delivering either primary or specialty palliative care, or both, depending on the type of work they do, understand barriers and facilitators to disease and symptom management from their perspective, and also solicit some of their ideas regarding how to improve both care coordination and delivery of palliative care within a primary care setting. So I will start by saying these are very preliminary findings. Our work is still ongoing, both in terms of continuing to recruit patients for interviews, and also for continuing to do a more, rigorous analysis of the data. But given this opportunity, I did want to at least present some initial themes that are coming up in the interviews and transcripts. And I'm going to focus specifically on what's coming up in the interviews of patients and caregivers, again, who are receiving home care services. And the top level and most consistent things that we're hearing are that mobility challenges really do prevent patients from both getting palliation of the symptoms that they're having, and also getting that timely access to urgent care needs or preventive care needs that might prevent them from ending up needing to go to the emergency department, or ending up being admitted to the hospital, or having something really get exacerbated. And I'll show you some quotes that really exemplify that. The second theme that came up is the importance of responsiveness of clinicians. And we're fortunate that the patients who we were interviewing, who are receiving care, through this primary care practice, and with a really dedicated nurse practitioner who provides home care, people really saw the fact that they receive a very timely response. They have a direct line via email and telephone, that they can get, prescriptions filled. If there's, a change in symptoms or a change in status, they can call and talk to somebody right away. And if there's a service that's needed, they can get the service right away. So not only did the responsiveness potentially have the potential to reduce symptoms and also get timely preventive care, or timely care to address an urgent need, it also really helped alleviate stress and improve quality of life. Because I think all of us can experience the feeling of trying to reach out and not really, receiving a response in a timely fashion, and the stress that provides on us. And lastly, what really stood out to me is that patients and caregivers are not familiar with the term palliative care, but they are familiar with palliative care services, and do believe that that is what they are receiving, and believe it's very important. So when we mentioned palliative care, nobody seemed to be familiar with the term, and they asked for it to be described and defined. But once it was described and defined, they really identified, yes, those are the types of services I'm receiving, and I think they're really important. So I put a couple quotes in here just to really, exemplify some of these themes. This patient was saying, that she really needs to make a major voyage to get to the hospital. That's how she sees it, if she needs to go see a physician. And if I can't get to the hospital, well, I'm just not going to go in. And I'll just fast forward for time. This person felt that they needed to really practice the ride into the hospital. And if they felt that it was too much for them to tolerate, they wouldn't go get a service that was indicated for them, and that was needed for preventive care, so that a skin condition did not become worse. And here's some quotes from a caregiver talking about, prior to having home care services, just feeling that it was very hard and very, very frustrating, because it's such a huge time block out of the day when you're taking somebody with limited mobility to a doctor's office. And now with home care, not only is that aspect alleviated, but with, with a direct line to someone who, is responsive, can get medications refilled more quickly. If there are symptoms, this person can call and get suggestion on how to handle it or change medication, or send another provider, in this case, giving an example of sending additional providers in who could provide services in the home, and the quality of life is increased because they don't have to keep going out to appointments. And a similar report here from a different caregiver really felt that the benefit was having so many additional providers being able to come to the home, and also being able to come to the home in an emergency or urgent situation to address a need. In this case, an issue with an ingrown toenail, having the ability to call a podiatrist who can come to the home and then take care of something before it becomes a larger issue. So now I want to transition just to give a brief overview, and I want to be conscious of the time. Just want to give a brief overview of the actual intervention that we're doing as part of this pilot. So our aim was to develop a comprehensive primary palliative care program for patients with multiple chronic conditions who are actually able to come into the clinic and try to provide some of the level of service that people who are receiving home care get, but for patients who are actually ambulatory and come into the clinic. So we focused on provider education, standardized assessments and documentation by creating a standardized note within the EPIC universe, and also implementing a care management team-based approach. So just very briefly, everybody completed the End-of-Life Nursing Education Consortium, or ELNEC, courses. We also curated a list of courses available from some other organizations so that providers can pick and choose where they felt that they needed additional education that would be helpful for providing patients with palliative care, and also discussing palliative care and advanced directives with their patients. And we also completed, or I should say offered, lunch and learn type sessions led by Maureen McHugh to really go over, how to utilize some of the assessments that we were implementing in order to better serve patients. So as part of the standardized assessment, the note included information that was more enhanced regarding the backgrounds of patients, right? So who are their caregiver supports, emergency contacts, language, religion and spirituality, and social determinants of health. So the idea here is not only is it helpful for the primary care provider to be aware of all of these topics so that they can provide better services in the outpatient setting. The idea here is that if patients did end up in the hospital, there would be notes and records that would be viewable to the clinicians on the inpatient side to sort of help provide some context and background for the patient that would allow more appropriate and targeted care for their needs. Next, we have scales that we included for enhanced symptom, pain, and functional status. So the Edmonton Symptom Assessment Scale, the Karnofsky Performance Status Scale, the Palliative Performance Scale, the PROMIS Fatigue Measure, the PROMIS Pain Measure, and the PROMIS 36 Overall Health Survey. So these were included as tools that providers can use, at an initial assessment, and then over time to see if there are any status changes that needed to be addressed. We also added some prognostic indicators such as trending albumin, weight, and any recent imaging. And lastly, we had a focus on starting conversations about advanced directives and goals of care, and if patients were willing and interested in, making advanced directives, to make sure that those were achieved on file. The last thing I want to mention is this really was predicated on a new team-based approach to care management. So with partnership through the NYP Accountable Care Organization, we worked with Judith Thorpe, who performs assessments via telephone prior to the patient's visit and then the nurse practitioner can incorporate that data into the care assessment. And then Judith follows up weekly or as needed with the patient to, address any, changes in status or needs that the patient might have. And I will say, before we're still in the process of doing this project, but this really illuminated the importance of having a really, really skilled nurse care manager because Judith has picked up on countless, issues that needed to be addressed for patients, and I think has built a lot of relationships with patients. So that's one of our lessons learned in this pilot is the value of having the appropriate care manager in that role. So in our last minute, I'll just give a really quick update on our aim 3, which is to assess the feasibility, acceptability, and perceived utility of the intervention. And again, I know we're running short on time, so I'll just say very briefly, we are piloting the feasibility of collecting all of these data points. We're going to be interviewing our providers as our intervention comes to a close to understand the acceptability and perceived utility. And we're also going to be interviewing patients and caregivers about their experiences. And just to give a brief update of where we are in terms of our recruitment, in terms of acceptability from the patient perspective, 17 patients were approached and invited to participate in this, enhanced level of care. 11 accepted, and 8 were able to continue along and were willing to continue along with the intervention. And I know we're running out of time, so I'll just say a couple of top-level feasibility challenges that we have thought about and will continue to think further about is obviously we had a lot of turnover both in terms of patients and changes in providers. There are some challenges in terms of how to most effectively target when these assessments should be given and by whom. There are also billing considerations because obviously our insurance processes are such that we need to make sure that we have the appropriate billing codes and that this work is being captured and appropriately billed for. The EMR documentation had several challenges, and particularly challenges with things that are recorded in the outpatient environment being accessible to clinicians in the inpatient environment and vice versa. And lastly, there were some challenges with institutional policies and institutional accessibility to some of the important features, such as the ability to access the EMOS system in the outpatient setting. So we hope to explore all of these further in our full feasibility assessment when the pilot finishes at the end of this spring. And lastly, I do want to acknowledge this is a large and incredible team, and everyone brings, a different expertise to the table. So I really just want to appreciate everyone who has been involved with this over the past several years. And of course, thank you to CIPC for providing the funding for this project.
Thank you very much, Dr. Cohen. So now let's move on to Dr. Song's presentation. And I just want to thank you all for coming to this presentation. I saw a lot of our doctor students, postdoc and faculty, and also our collaborator. And thank you, Dr. Kale from NINR is also here attending this presentation. So I just want to acknowledge the support from NINR for our CIPC Center. So Dr. Song, are you? Can you pull up the slides?
Yep, let me share my slides. So everyone can see my slide? Yeah. So let me start. So thanks for giving me an opportunity to present the CIPC Center pilot research project entitled Identify Preference of Palliative Care Through Conversation Cold Reflection Study. So my name is Jiyoun Song, third-year postdoctoral research fellow at Columbia University School of Nursing. So here is a brief overview of the study background. So managed long-term care is a system that streamlines the delivery of long-term services to people who are chronically ill or disabled and who wish to stay in their home and communities. So managed long-term care is one of the several demonstration programs across the country with goal of providing better and more coordinated care for individuals while reducing healthcare expenditures. So due to the decreased length of hospitalization and the improved healthcare technologies, healthcare delivery shifted from the hospital to their community. And in addition, with longer life expectancy and the prevalence of chronic disease among the elderly, more acutely ill patients with complex conditions are expected to receive care at home. Every year, more than 3.3 million older adults receive care from more than 13,000 home care agencies across the United States. So palliative care programs aim to relieve patient symptoms and disease-related stresses. Patients receiving managed long-term care will benefit from holistic approaches of palliative care to reduce physical symptoms such as pain, nausea, fatigue, and to help improve mobility and to promote psychosocial well-being. So given that approximately 85% of patients receiving the services are over 65 years of age, suffering from multiple chronic conditions and having significant symptom burden such as pain and fatigue, and more than 20% of patients died with a year of admission of home care. So palliative care is beneficial to patients receiving managed long-term care at home. Many patients prefer to receive palliative care at home due to the familiar environment, sense of independence, privacy, access to family and friends, and the ability to maintain daily routines. When providing palliative care to managed long-term care patients, healthcare providers, including physicians, nurses, physical therapists, or social workers, provided palliative care to meet the patient needs, such as elevating their pain and other symptoms, and meeting their emotional and spiritual needs, or assisting the patient and their family to understand their disease and diagnosis, to assist the patient in making informed decisions. So when a managed long-term care patient is eligible to enroll in palliative care program, case managers such as nurses or social workers reach out to them and discuss the patient preference of palliative care over the phone. So in spite of evidence that the need palliative care has increases and that early palliative care results in improvement of patient outcomes such as quality of life, symptom, and physical and psychosocial functioning, patients do not always accept palliative care. So however, little is known about why they don't accept palliative care. So therefore, by understanding the barrier and facilitator to palliative care acceptance, we are able to develop alternative approaches that will help as many patients to accept palliative care as possible. So given that patient and healthcare providers interaction are information seeking and sharing behavior, patient can express explicit information such as perception, feeling, and needs that can give more important clue about palliative care preference during verbal communication with healthcare providers. There have been a few qualitative studies assessing the barrier in palliative care from the point of view of healthcare providers, but no studies have been conducted that has analyzed the conversation using advanced data science methods such as speech recognition technologies to extract insights from verbal communication. So previously, our team demonstrated a method of analyzing patient and nurses' verbal communication in home health care, and our team also found that conversation revealed 30% more problem and intervention not captured by the electronic health record or clinical notes. So therefore, this study will investigate a data source that is previously untapped, large, and potentially informative case manager and patient conversation when initiating palliative care discussion to understand factors that affect acceptance of palliative care. So we will use a large, diverse patient cohort from BNS Health, the largest nonprofit home care agency in the United States, and the approximately 400 phone call conversation recorded for more than 300 patients from October 2021 to June 2022 will be used. For the patient demographics or other functional assessment, we will use institution's electronic health record and Uniform Assessment System, UAS, which is a comprehensive assessment system designed to determine the amount of care required in home and community-based setting. So first aim is to identify palliative care contents in patient and case manager audio recorded conversation. So we will use both transcript of audio recordings at the utterance level, which is the stretch of spoken language preceded or following by silence or the change of speaker, to manually identify and annotate conversation content related to palliative care, including barriers and facilitator. And we will also use the audio recording itself to analyze voice signal to extract acoustic content. So the Rotor Interaction Analysis System, RIAS, is a widely used tool for coding medical conversation, will be used to code audio recordings. So RIAS categorizes element of communication as task focused, that is procedure or medical question, or socio-emotional, that is social talk, positive talk, expression of emotion or concern, something like that. And then on the transcript of the conversation, each utterance will be manually annotated with the one or more categories of the RIS categories. In addition, we will build a natural language processing algorithm to process transcribed conversation to identify expressions such as words and phrases using during the conversation. So we will apply the natural language processing algorithm on transcript of the conversation to identify palliative care concept, including goal of care and preference, including positive semantic expression. So for example, during the conversation, if the patient asks, what is the palliative care? So it will be annotated medical question based on the RIAS system, and then the word palliative care will be detected as contents of palliative care based on the natural language processing algorithm. So lastly, we will analyze voice signal to extract acoustic content. So we will use a discrete transform technique, including the Bell scale frequency setup coefficient and the discrete cosine transform and the discrete sine transform. Those are the technique for analyzing and measuring voice intonation, voice energy, and the voice noise level. So for example, to analyze voice intonation, the fundamental frequency of the voice directly related to its intonation will be evaluated. And then we will also evaluate the temporal aspect of the speech, such as total duration of speech and phonation time and speech rate and total length of pauses. And second aim is to develop and test prediction algorithm to identify patient preference for palliative care based on their conversation. So we will develop machine learning-based prediction algorithm using extracted information derived from the AIM-1, so structured data, and then structured data, which is including electronic health record and uniform assessment system, and patient and case manager audio recording conversation, which is extracted from the AIM-1. So it will include information regarding the characteristic of patient and contents of the conversation based on the RIAS categories, word or phrases extracted from transcribed conversation using the natural language processing technique, and the length of conversation, the ratio of clinician to patient talk, and the tone and pitch of the voice. So lastly, we will evaluate performance of prediction algorithm to identify a patient preference for palliative care. And third aim is to explore the relationship between self-reported symptom and palliative care preference using the mixed method approaches. So we will recruit 10 patients, 5 who accept the palliative care and 5 who refuse palliative care. So then self-reported symptoms regarding pain and fatigue using the questionnaire will be collected to determine if level of pain and fatigue influence acceptance of palliative care services. In addition, we will conduct a brief interview with the patient to determine how they manage this symptom and to observe the relationship of this symptom and their management on the impact of palliative care acceptance or refusal. So with this algorithm, so we can determine the patient preference for palliative care early on and implement different strategies based on their preference to encourage as many patients as possible to may benefit from it to accept palliative care. So the current study, this is the first time that the institution have attempted to utilize such data source, especially the audio recording. So for this pilot study, so currently, so we have secured the environmental condition to use this first type of data source. And as of now, so we have collaborated with the data science team at the BNS Health, where the audio recording of phone calls are managed in the data warehouse and have identified the path to transfer them. So once the data has been transferred very soon, so we will begin an in-depth investigation for this study. So thank you for your attention. I would appreciate any question you have.
Thank you very much, Dr. Song. It's very exciting to hear the progress of your study. We look forward to hear to more results when it comes out. Okay, so we only have 3 minutes left. We're going to open to the question from the audience.
Well, I thank you all for your great presentations. And this isn't so much for Dr. Song because he's just getting started. But the question I have is, these are pilot studies, you know, the center is to build on to make for others. Do you have any plans for further studies, or has this informed anything? And so Bevin, Maureen, both of you?
I'm happy to just say, briefly, I think we mentioned this the other day in our, smaller group meeting. For us, I think one of the major themes to come out is that despite the, education efforts that have been done, previously for many decades by other investigators, we're still finding that patients are not really equipped with the, knowledge to engage in conversations around advanced care planning, and that it seems to really take many interactions with healthcare providers before people are really even willing to start engaging, which I think is sort of consistent with the literature. So I think one of the things that we're hoping to do is potentially look at maybe developing or adapting some previous interventions that can help patients just become more equipped and comfortable for having those conversations, and really think about the types of information that they might need that maybe are lacking.
That's great. And the one thing you didn't say, but this work has already had an impact, Bevin. When you found out that the outpatient records did not go into the inpatient records, and so therefore, the advanced care planning that was done as an outpatient, and that's been changed. That's pretty impressive.
Yeah, and I will say, I mean, no credit to me, but to the people who are working on this pilot. They're the ones who identified that, and this sort of gave the opportunity to discuss it and move it up a chain. But they've identified a lot of issues like that, and it's really great that there's an avenue for them to pursue. Yeah.
Yeah. And Maureen, any future plans for?
Oh yeah, this is the feasibility part where we are going to train the nurse practitioner and then run this this communication training through 10 patients is really going to provide the the preliminary data we need to put in R21. Maybe when it triangulates with the other asthma work, maybe we could even look at an R01, because I've done it in adult and pediatric asthma, and this is not that dissimilar. So maybe there's enough preliminary work, it would be an R01.
Great, great. And Jiyoun, I'll be asking that as soon as you get your data done. Thanks, everybody. Anything else, Jingjing?
We are right at 1 p.m. So if you have any questions you want to ask of these pilot PIs, feel free to send the emails to Quadra. We'll collect those emails and send it to our PIs.
Thanks,
Thank you.
everybody.
Thank you.